Yeah. Okay. Sounds like everything has started. So, welcome. Thank you, everybody, for attending the second annual MVSS APP webinar. My name is Nate Kugler. I'm one of the vascular surgery attendings that works at the Medical College of Wisconsin with both Victoria as well as Maria, who are here today. So I'd like to thank you for attending the webinar. So the focus here is on really APPs as well as the teaching opportunities on several different topics that you're going to hear about today. The committee that puts this together is consumed by Dr. Casper as well as Dr. Rossi, Laura Needler, as well as Maria Wellenstein, who put all of this together. So I'd like to thank them for putting an excellent program together. And I think the topics look very interesting and very applicable to vascular surgery today. So it's an awesome opportunity, I think, for us to learn from APPs as faculty, as well as you all to learn from each other. So sharing your kind of knowledge and expertise, and certainly a different take on many of the patient care issues that we have today. So I'll turn it over first to Maria to introduce our first speaker, who's talking tonight.
Hi, everyone. Thank you for coming. So first up, we have Lauren, and I'm sorry if I'm going to pronounce this wrong, Brochert. She's a nurse practitioner. She works in the outpatient setting at Northwestern University in Chicago, and she has worked for over 10 years in vascular surgery and has a vast amount of other nursing experience in the vascular cardiovascular world. She's going to be presenting on the management of asymptomatic vascular disease. Thank you, Lauren.
Great, thank you. Can everyone see my slides?
Yeah.
Perfect, thank you. So I'm going to be talking about the management of asymptomatic vascular disease. My slides will advance. There we go. We're going to be using the grading guidelines from the Society for Vascular Surgery, or the SVS. So when you look at the recommendations, it's going to be based on the level of evidence. So the grade talks about strength of recommendation. A strong level 1 recommendation is we recommend, which means the benefits of an intervention outweigh the risks, or the risks outweigh the benefits. A weak strength of recommendation is we suggest, so the benefits and risks are less certain and might be more dependent on specific clinical scenarios. And then the level of evidence, if they have a level A, there's a lot of evidence supporting it. Additional research is very unlikely to change our confidence in this recommendation. A level B, further research may have an important impact on the estimate. Or level C, further research is very likely to change. And then a good practice statement is an ungraded recommendation advising about performing certain actions considered by surgeons to be essential for patient care and supported only by indirect evidence. So as we're talking about some of these recommendations, it's just helpful to know what the strength and graded recommendation is. First, we're going to touch on peripheral arterial disease. This is something that we all treat. We see in the clinic every day. About 20 to 59% of patients with objectively proven PAD are asymptomatic. So that means that they have an abnormal ABI waveform or toe pressure without claudication, rest pain, or tissue loss. It can also be found on CT scans by narrowing of the aorta or iliac arteries, but it is associated with increased risk of MACE, which is major adverse cardiac events. So we typically recommend optical medical management, including a walking program, either structured with a cardiac rehab or a patient-driven. I teach my patients about daily foot care. I tell them not to walk barefoot, to look at their feet every day, make sure they don't have any new wounds. And then we recommend antiplatelet, statin, good blood pressure management, diabetic management, and weight management. The SVS recommendations for asymptomatic PAD are basically a multidisciplinary comprehensive smoking cessation intervention. That's the highest grade recommendation. And I know the SVS has really been pushing towards that. And we at Northwestern have also been really working on getting these patients to quit smoking. They recommend against invasive treatments for asymptomatic PAD regardless of imaging findings, and that you educate patients about signs and symptoms of PAD progression, which is just a good practice recommendation. I would say the only caveat to this is we are a transplant center. So some of our patients are getting worked up for kidney transplants, and we'll have iliac artery stenosis that is asymptomatic, and we will treat that before they undergo their kidney transplant because they anastomose to the iliac artery. Next, we're going to talk about carotid disease. So just for screening for carotid disease, the SVS recommends against screening the general population without symptoms or risk factors for cerebrovascular disease, and that's a high-grade recommendation. But it is reasonable to screen patients who are at high risk for carotid stenosis as long as they're willing to undergo intervention if a clinically significant stenosis is found. If they're not willing to do anything about it, we don't need to go looking for things. And a carotid duplex is recommended for screening from an accredited vascular lab over a CT or MRA. We don't treat patients who are asymptomatic and less than 70%, but low surgical risk patients with greater than 70% stenosis by duplex or CTA, we recommend CA over optimal medical management for long-term prevention of stroke and death, and that's a 1B recommendation. But asymptomatic patients with severe stenosis bilaterally or severe stenosis with contralateral occlusion undergoing CABG, they recommend a CA before or combined with CABG. I think that TCAR will change a little bit of this. You know, the recommendations don't talk about the transcarotid stenting in terms of, I think more patients will be acceptable risk for procedures at that point, but we still just don't have the data behind. For mesenteric stenosis, we like to review with the patients the symptoms of mesenteric ischemia because a lot of times they also have underlying GI issues. So we want to make sure that it's definitely mesenteric ischemia and not a GI issue. Optical medical management is very similar to PAD. We make sure they're on an antiplatelet, statin, control their blood pressure and diabetes. And we typically have patients do a symptom diary. We want to make sure they're not having the postprandial pain, they're not having belching, they're not having weight loss, they're not having food fear. The SVS recommends a shared decision-making approach for asymptomatic patients and providers to discuss revascularization as a treatment option, but it's a low-grade recommendation. They also recommend asymptomatic patients with severe mesenteric occlusive disease be closely monitored for symptoms consistent with chronic mesenteric ischemia, and they recommend using a mesenteric duplex annually for this. For AAA, I know we're going to have a couple of talks later about AAA, so I'll be brief. But for medical management of AAA, they recommend referral to a vascular surgeon at the time of diagnosis, which is good practice. I know we sometimes get very, very small aneurysms sent to us and we don't really do much to them, but I think it's helpful for the patients to understand their disease process and what to look for and just kind of reassure them because we are the experts in this area. They do recommend smoking cessation to reduce the risk of expansion and rupture. And they recommend against adding statin, doxycycline, rexithromycin, ACE, ARB, or beta blocker for the sole purpose of reducing risk of expansion and rupture. So you can add it for other reasons, but not just because they have a AAA. And then intervention for asymptomatic AAA, they recommend elective repair for low to acceptable risk patients with a fusiform aneurysm at 5.5 centimeters. Elective repair for saccular aneurysms. This is a pretty low grade recommendation. And I know among my surgeons, a lot of it is very patient specific, whether or not they'll intervene at a lower threshold for saccular aneurysms. They recommend elective repair in women between 5 and 5.4 centimeters and shared decision-making in patients with 4 to 5.4 centimeter aneurysm requiring chemo, radiation, or a solid organ transplant. For the descending thoracic aortic aneurysm with TEVAR, they recommend TEVAR in asymptomatic patients when the diameter reaches 5.5 centimeters in a low risk patients who have a suitable anatomy. Higher threshold for those at higher risk for death, renal failure, or paraplegia from the procedure. For asymptomatic intramural hematomas, which is shown in the middle on the part B, you can kind of see the clot on the inside there. They recommend close observation with hypertension management and follow-up imaging to monitor for dissection. So we typically do that if they're in the hospital at 48 hours, 1 month, and 6 months. And same thing for penetrating aortic ulcers. They recommend TEVAR for penetrating aortic ulcers for patients at risk characteristics for growth or rupture. For the visceral aneurysms, I love this slide that the SVS put out. I reference it all the time because I never remember all these arteries in the mesentery, what we're supposed to do with them. So for gastric and gastroepiploic arteries, you repair them regardless of the size. splenic artery, all pseudoaneurysms, or size greater than 3, or in women of childbearing age. Celiac artery, all pseudoaneurysms and size greater than 2 centimeters. Renal artery, greater than 3 in women of childbearing age, or if they have refractory hypertension and renal artery stenosis because of the aneurysm. Colic arteries, we repair all aneurysms regardless of size. Jejunal and ileal arteries, greater than 2. SMA aneurysms, repair regardless of size. For the pancreaduodenal and gastroduodenal arteries, repair all aneurysms regardless of size. And for the hepatic artery, greater than 2 or growth of greater than 0.5 in a year. Last but not least, we have popliteal artery aneurysms. The SVS guidelines recommend asymptomatic patients with popliteal artery measuring greater or equal to 2 centimeters undergo repair to prevent thromboembolic complications and limb loss, because popliteal arteries don't typically rupture, but they do throw clot. Asymptomatic patients with life expectancy of at least 5 years, they recommend open repair if adequate saphenous vein, otherwise consider endovascular repair. We typically do a high quality CTA to see what their runoff is if we're considering endovascular repair. They should have at least a good 2 vessel runoff if we're going to consider doing endovascular, but we do prefer open repair with GSV. And asymptomatic patients who are not offered repair should be monitored annually for change in symptoms, a pulse exam, extent of thrombus, outflow patency, and aneurysm diameter. We recently had a patient who had a 6 centimeter asymptomatic popliteal aneurysm. It was very evident on exam. You could see it, you could feel it, but he was not having any thrombotic complications. So we actually did his surgery the next day with saphenous vein, and he's doing very well now. And that is it. Thank you.
Thank you very much. What a wonderful presentation, a nice overview of all the different aspects of asymptomatic vascular disease. I'll open it up to any questions that people may have, but I'd like to start with one question for you. I think the biggest new hot topic is PAD Xarelto, particularly in, the asymptomatic patients, and it kind of bridges across different aspects, whether it's PAD or carotid disease and that. How have you all integrated kind of like the low-dose Xarelto into your patient population as a part of like preventative nature in these asymptomatic people?
I feel like we haven't added a lot for preventative measures. We have added it a lot for patients who are going to do stents or bypasses, and we don't want to fully anticoagulate, but we'll do the PAD. But we haven't done it as I guess, per the guidelines, the recommendations to add it for asymptomatic patients at this point.
Excellent.
Lindsay, I have a question. This is Maria. For the AAA and the statin therapy, are you finding yourself still starting statins though because of VQI and most of them also having peripheral artery disease?
Yes, I mean, we pretty much have all of our patients on the statins regardless of that recommendation. Yes, because of the VQI. And most of them honestly have coronary disease or peripheral arterial disease. They have another indication for it. So it's very rare that they don't meet criteria for a statin.
Yeah, I think it's pretty common. I think the point that you made is excellent, which is all these things sort of go together in many realms, PAD and coronary disease and carotid disease, et cetera. It's not a disease process as often that affects one vessel in and of itself. So. Well, thank you very much for that presentation. It was wonderful and very informative. I think if I had to put a plug for anything, it would be that excellent chart that the SVS put out from the Rare Disease Consortium that is certainly referenced on my phone and sent to all of our fellows and residents because they can never remember it, nor can I. So it's a good one to reference all the time for people that are logged on tonight. So excellent. Thank you very much. So we'll move on to our next presentation. So I'd like to invite Claire Murray, who is a nurse practitioner at TriHealth Health Systems within Cincinnati, Ohio. She's worked there now for at least 3 years, as I understand, in the heart and vascular service line, specifically within vascular surgery. She's going to give us a nice presentation tonight here, focused on carotid duplex, mesenteric duplex, and aortic imaging as a part of the management of vascular surgery patients.
Thank you so much. Hi, my name is Claire Murray, and I have the pleasure of working alongside the TriHealth Vascular Surgery team in Cincinnati, Ohio. This is our home base in Cincinnati. Like many of you, I work in a high volume practice with a variety of complexity. I'm sure we can all relate to these pictures with the amount of intricate cases we follow and manage that our surgeons perform. Personally, I would like to blame Dr. Muck and his partners for any gray hair that I have. Sorry, Dr. Muck. All of the guidelines I'll be reviewing tonight are from the 2018 SBS, or Society for Vascular Surgery, as this is the most up-to-date set of guidelines. We'll jump right in with a carotid endarterectomy case from 2014. Let's first take a look at the box on the right with the parameters and velocity criteria. This patient had a PSV of 524 and an EDV of 156, which prompted a CTA confirming high-grade right ICA stenosis. As of 2012, we now have another option for carotid disease with the TCAR. Here at TriHealth, we do a lot of TCARs and are the #1 site in Ohio. Following CEA or carotid stenting, SBS recommends carotid duplex at baseline, typically within 3 months, and every 6 months for 2 years, and then annually after that. As vascular surgery has evolved, many surgeons, including within my practice, are performing more complex cases than ever before, including TVARs, PMEGs, and FEVARs. As we move into aneurysm surveillance, we have imaging of a ruptured thoracic aneurysm, and then on the left, and then on the right, you can see they are status post TVAR, or a thoracic endovascular aneurysm repair. This is the case from a PMEG, which is a physician modified endograft. Now we will review the ongoing surveillance following aneurysm repair. For TVARs, it's recommended that we obtain a contrast CAT scan at 1 month, 12 month, and then annually. Aortic dissection, obtain a CT at 1 month, 6 months, 12 months, and then yearly. EVAR, check a CAT scan at 1 month, 12 months, and then a duplex in addition to the CAT scan at the 12-month period. If any of these do show an abnormality or endo leak within the first scan, it's recommended to check them at the 6-month period. Total aortic imaging is recommended at 5 years for both open and EVAR, thoracic and abdominal repairs. And this on the right is an example, well, it's a case of a PMEG. Surveillance following more complex interventions, such as a FEVAR, post-SMA stenting. Guidelines recommend clinical follow-up and a baseline duplex within 1 month, 6 months, 12 months, and then annually. If the patient is symptomatic, it's recommended to check a CTA to evaluate for recurrent mesenteric ischemia. Surveillance following renal interventions with renal stenting include a renal duplex at 1 month, 6 months, 12 months, and then annually. SBS recommends checking a CTA if clinically indicated for parenchymal loss. Transitioning into occlusive disease with suprainguinal and infrainguinal bypass grafts for chronic limb-threatening ischemia. Duplex velocities greater than 300, as you can see on the left, it puts patients at a high risk of bypass failure. And this is just a case of a before on the left, before a femoral distal vein bypass graft, and on the right would be after the bypass. Guidelines recommend a set of ABIs with or without duplex at 1 month, 3 months, 6 months, 12 months, and annually. Onto our endovascular intervention surveillance. The reason that we do endovascular intervention surveillance is to monitor for intimal hyperplasia versus recurrent disease. The SBS recommends clinical exam, ABI, and a duplex imaging within the first month, at 3 months, and every 6 months. Of course, if there is any change such as new tissue loss or rest pain, repeat duplex should be obtained at that time. This is a good summary of the guidelines. I'm happy to share this presentation with anyone who's interested. I look forward to meeting you all at the MVSS conference happening here in Cincinnati, September 18th through the 20th. It's going to be a great time. Thank you all for listening.
Excellent. Awesome plug for the in-person meeting coming up. So nice presentation, a very good overview of the guidelines. I mean, certainly there's a fair amount of variability somewhat in people's practices. I think one of the ones that I always struggle with is a common one. You know, we do a lot of renal artery stenting for symptomatic hypertension and people with multi-drug. How do you all, you mentioned nicely kind of what the guidelines reflect with respect to how to sort of surveil these renal stents. But when you have somebody that's been very much improved clinically, so good control of their hypertension, but maybe their duplex suggests a bit of stenosis, what's your go-to in terms of how you kind of follow those people up? Because I find it to be a clinical challenge. You know, they're clinically better, they're not hypertensive anymore.
Yeah.
And so how do you go about sort of deciding when to reintervene, or what's your sort of go-to algorithm for that?
Yeah, I actually have a patient right now that I'm kind of in between that. So their blood pressure is controlled. They were on like 2 or 3, I think, antihypertensives, but their blood pressure is the best that it's been. They did have a bump in their creatinine and decrease in their GFR. So depending, depending on what their kidney function is, we can always obtain a CTA. Or right now I'm considering a CO2 angiogram just because of the bump in her creatinine. So a CO2 angio would be my suggestion at this point for this patient specifically, if we can't obtain a CTA.
Hi, Claire, Maria again. So with the follow-ups with the TAMBIs and the more intense procedures, are you guys doing a quick 1-week follow-up, or are you just going to the longer period of time?
I'm sorry, say that again.
For any of the procedures, like your first follow-up to do like a groin check or wound checks, are you doing it within like 1 to 10 weeks, or are you doing it for an extended period of time?
Yeah, we do our 2 weeks follow-up following intervention.
And I got one last question. So the hot topic always comes to contrast for aneurysm surveillance post EVAR and whatnot. And so people that are, you get your initial 1 month, who are you opting to forgo contrast in the future versus contrast enhanced CT? Because certainly there's a lot more implications than just renal dysfunction in those people. I mean, it's, infiltrations, costs, time, et cetera, that goes into that. Are you getting non-con CTs on all these people, or who do you kind of decide you need contrast imaging long term?
Yeah, so if there is renal failures playing a role, we can do a endograft duplex to check for the endo leak, and then get a non-contrast CT for the aneurysm size. And then if that shows that it's enlarged, then talk about a visceral angiogram to evaluate for an endo leak.
Excellent. This may be pretty old school, but I miss the old school pressure monitors that we used to put in the aortic sacs. Now just only available for the pulmonary arteries anymore.
I
But
don't think I have not been around for that, so I
yeah,
have not seen
those are
that.
many years ago, but you used to be able to wave a wand over a person and determine what the pressure in their sac was, which
I'm
was
sure
quite
Dr.
nice.
Musk
But
is aware of them.
I'm
Yeah.
sure Muck knows about those. They were very helpful, and it was actually clinically quite helpful for some of the things. But
Yeah.
nonetheless, it is what it is. So, oh, Dr. Muck put in he apologizes for any of the gray hairs. So, and I'm sure he knows
Thanks.
about the pressure transducers. So.
Oh, I'm sure. He's been doing it, yeah, a little bit.
Any other questions from the audience? No more gray hairs. So excellent. All right. Well, thank you very much for taking the time. I appreciate it. And I'll turn it over to Maria for our next presentation.
So up next, we have Lindsay Katzmark, who is a nurse practitioner at Children's Hospital in Milwaukee, Wisconsin. She has been specializing in congenital issues and Marfan's congenital disorders for over 17 years. It is a great pleasure having her. We hope to have her at our big meeting one of these days soon. Thank you.
Thank you, Maria. Victoria is going to help me with my screen sharing because I was having some issues. So pardon if there's some technical difficulties as we manage it together. I am going to be talking about hereditary thoracic aortic disease, a collaborative approach to diagnosis and management. Again, I'm at Medical College, Children's Wisconsin, and I also I'm adult trained, so I go in between Children's and Freighter with our congenital program. You can hit the next slide, Victoria. So I am going to start with a case review. A recent patient whose successful management required the work of several specialties, including our vascular surgery friends. I'm going to briefly review what Marfan syndrome is and try to highlight some of the differences between Marfan and other hereditary aortopathies. I kind of briefly acknowledge the management considerations that are often tailored to each condition. And since this case includes a patient with Marfan syndrome, I am going to circle back to the inevitable question, actually a pregnant patient with Marfan syndrome, was it safe for this patient to consider pregnancy? I have no disclosures except for I am not a geneticist or a genetic counselor, so take that into consideration if you're critiquing my knowledge of genetics. My background is congenital cardiology. Next slide. So this is a 38-year-old G1P0 female with Marfan syndrome who came into our ED at 29 weeks, 5 days gestation, presenting with acute back pain. Victoria, you can hit it a couple times. Additional history included a secundum ASD, status post-surgical repair at age 6, valve-sparing aortic root replacement at age 30. She had a trileaflet aortic valve with trace aortic regurgitation, mitral valve prolapse with mild mitral regurgitation, and a history of aortic dissection in her mother. The last known maximal aortic diameter was 2.7 centimeters in her infrarenal aorta. So her aortic root was replaced. Her arch was her native arch that measured normal, and her descending thoracic aorta was also native to her, and it measured normally. So the maximum dimension was at that infrarenal aorta that was done in 2020 prior to her presentation. Vitals are as follows. So she was pretty stable at the time of presentation. Next slide. Laboratory analysis was also pretty stable. She had good evidence of end organ function. Her creatinine was normal. She didn't have any lactic acidosis. So you can hit it again. We proceeded with a chest CT angiography for evaluation. And as you can see, as these have a mind of their own currently, but as you can see, there is a type B dissection that originates just below that left subclavian, and you can't see how far it extends down, but it terminates right below the renal arteries. So she had a zone 3 to zone 8 type B dissection, and her abdominal aorta at the level of the renal arteries measured about 4.6 centimeters. You can go to the next slide. Again, like I said, zones 3 to zones 8. With a acute type B aortic dissection, then with the maximal dimension was 4.6 centimeters at the renal arteries. Next slide. So we collaborated with vascular surgery, our congenital team, and maternal fetal medicine, and admitted her to the SICU for impulse control. Given the gestational age, so a reminder, she was 29 weeks gestation at the time, we favored medical management with control and close monitoring until she was a little bit further along. Initially, we were pretty aggressive with our heart rate and systolic blood pressure parameters, including a heart rate of less than 80 and a systolic blood pressure of less than 90. We were able to maintain that with nicardipine and esmolol infusions, and then ultimately with serial CTA imaging, we did move towards liberalizing those parameters with a systolic blood pressure of less than 120 and a heart rate of less than 80. We also transitioned her to an oral regimen with labetalol, diltiazem, hydralazine, and nifedipine. Unfortunately, because this wasn't complicated enough, she developed preeclampsia with severe features and went to have a C-section delivery at 32 weeks gestation. Next slide. So she did well post C-section, and on postpartum day 5, she underwent a percutaneous transthoracic endovascular repair of the dissection using a single branch thoracic endograft terminating just above the diaphragm. Her plan in the future was for an open repair of the thoracoabdominal aneurysm, but this was done prior to discharge. Next slide. This another, picture of her endovascular repair that she had. Next slide. So post-procedural day 2, she was doing well, stable imaging. She did not have any cardiovascular symptoms, and she was ultimately discharged home on several antihypertensive agents. At 3 weeks post-discharge, she was seen in our clinic and was asymptomatic. And then, unfortunately, 2 months after discharge, she was seen by vascular surgery. And CT did demonstrate a rapidly enlarging thoracoabdominal aortic aneurysm with about 5 millimeters of interval growth in 3 months. You can click again. So she proceeded with a thoracoabdominal aortic repair. So she had an open extent 3 with a 26 millimeter 5 branch graft from the descending thoracic aorta to the distal abdominal aorta, with separate branches to the celiac artery, superior mesenteric artery, right renal artery, left renal artery. She had VA ECMO for distal aortic perfusion and cryoablation of the left intercostal nerves. Next slide. So I am going to pivot a little bit. So that she was discharged on post-op day 6, had an expected recovery without significant complications. But I am going to take this back a little bit to what I specialize in. So causes of thoracic aortic aneurysm, specifically related to genetic conditions or hereditary aortopathies, which in about 20 to 25% of the cases, there will be an underlying genetic condition. Next slide. So I think it's easiest to break this down into 2 different groups, syndromic disorders and non-syndromic disorders. Syndromic disorders are patients that have kind of this typical phenotype, so you can almost see them when they're walking around, or they come into clinic with some features that are very distinct for these conditions, so non-cardiac or non-vascular features, and those include disorders like Marfan syndrome, Louis-Dietz syndrome, vascular Ehlers-Danlos syndrome. Non-syndromic disorders, so those are people who really have no other physical characteristics that we can discern, but they have complications related to cardiac and vascular issues. So those that I'll highlight are the familial thoracic aortic aneurysm and dissection and variants of Louis-Dietz syndrome. Next slide. You can click it one more time. Maybe. So again, I'm going to go through some of these specific connective tissue disorders. So connective tissue is a pretty broad term. There are many different types of connective tissue disorders. Ones that I think we get the most exposure to in our cardiovascular world, I have highlighted Marfan syndrome, Louis-Dietz syndrome, familial thoracic aortic disease, and vascular Ehlers-Danlos syndrome. So I'm going to try to give some broad strokes today with regards to those conditions. One more. Next slide. Okay, so Marfan syndrome is an autosomal dominant condition. It is associated with a genetic variant in FBN1 or fibrillin 1. Incidence is about 1 in 5,000. And there are specific diagnostic criteria for Marfan syndrome. So major criteria is aortic root dilation and ectopia lentis or eye lens dislocation. But we can also see skeletal findings. These are, I think, these people that can be very tall stature, pectus excavatum or carotenotum, long fingers, scoliosis. What I think is always important to stress is skeletal findings alone, or a systemic score, we call it, alone, is not diagnostic of Marfan syndrome. Rather, it has to really be in combination with eye findings, aortic dilation, or an FBN1 gene variant. We can go forward. There is a high degree of clinical variability, so you can have in one family the same genetic variant. But it doesn't mean that it's always going to be expressed the same. Also, as it relates in different genetic variants within FBN1. So if there are different parts of FBN1 that are variable, then oftentimes you will see different expressions of that with patients. Next slide. Similar to Marfan syndrome, so Lewy-Dietz syndrome, actually, in the beginning, there was this kind of aggressive Marfan syndrome that people didn't really understand why it was so different than typical Marfan syndrome, and it was later discovered that it was a completely different gene variant, and it was termed Lewy-Dietz syndrome. This is also an autosomal dominant condition. There is syndromic Lewy-Dietz syndrome and non-syndromic Lewy-Dietz syndrome. So there can be, in the syndromic features, there can be symptom overlap with Marfan syndrome. Often we'll see very similar systemic scoring, scoliosis, pectus, those kind of things. Very important differences from Marfan syndrome is these patients will not have ectopia lentis. They often will have a bifid uvula or other palate abnormalities. We'll see club feet, and they have a higher risk for cerebral aneurysms, arterial tortuosity, and more aggressive aortic root dilation and risk for dissection. So oftentimes these are the patients that we are recommending very aggressive surgical interventions for when their aorta is often hit around 4.5 centimeters. Next slide. Non-syndromic hereditary thoracic aortic disease. So this is often what can be encountered even prior to diagnosis, especially in cardiovascular or vascular services. These patients often have a family history of aortic aneurysms. They present, they look pretty normal. There's no red flags when they're growing up. There's no scoliosis. There's no things that would really set them apart or give any sort of early warning signs. These patients will present with dissections in their third, fourth, fifth decades of life. And yeah, like I said, there is often no physical cues or clues that we have. This group of disease really makes up a lot of the genes that we continually discover. So years ago, there was very few genes that were known associated with hereditary thoracic aortic disease. And now that every year there's 3, 4, 5 additional genes that we find that are associated with this condition. So it is, again, an autosomal dominant condition. Only 30% of the time they'll have a first-degree relative with thoracic aortic disease, but what ends up happening is when a patient is diagnosed with a dissection and you test their for that same gene variant, you'll often find that they have aneurysms and they just didn't know that. We can look at the next slide. So I included vascular Ehlers-Danlos syndrome in here because I think that, especially for a vascular service, these are the ones that often tend to be the most traumatic, not only for the patients, but also for the providers. It is an autosomal dominant condition. They can have physical characteristics, thin translucent skin, extensive bruising. They have some characteristic facial features. There can also be times where these patients don't have any of those things and they present or they appear with numerous aneurysms or dissections. They are at risk for dissections and ruptures at normal dimensions. They're at risk for organ ruptures, and their tissue is known to be very friable and abnormal. Next screen. So there are many, like I said, there are many known genes that we have now that are associated with hereditary thoracic aortic disease. And it's important to note first that only about 20% of the time do we have a patient that had an aneurysm or dissection or a family history of aneurysm and dissection that we are able to say, yes, there is this gene variant associated. That means about 80% of the time families have a clear hereditary condition, but they have non-diagnostic or negative genetic testing. Doesn't mean they shouldn't be followed. It just means we don't exactly know what they have yet or what genotype they have yet. Of the known genes that we have, though, we have really worked to tailor management based on the specific condition and what is known about the risks of this condition and the natural history of that gene variant. So we often intervene at smaller dimensions on the aortic root and follow aneurysms or look for aneurysms in other parts of the aorta and vascular tree in many of these conditions on a routine basis. Next slide. So I am going to circle back to the case that I presented. So pregnancy increases both the heart rate, blood pressure, volume, and workload of the heart and surrounding vasculature. We can often see rapid dilation or degeneration of the aorta during pregnancy. Like I said, we try to tailor management. So we do prophylactically replace aortic roots when indications are met, usually around 4 to 4.5 centimeters prior to pregnancy. Also, we try to get CT scans prior to pregnancy to really help us risk stratify that pregnancy. However, outside of our institutional practice, there's really no common guideline for how, when, and how often to screen other parts of the aorta about the aortic root. And nor is it well understood what the risk is for a type B dissection during pregnancy, even at a normal dimension. So yes, it was safe for her. And while we did not expect for her to have a type B dissection, we know that there is a predisposition to that risk. Next slide. So we have, a great collaboration with our vascular service and management of patients with syndromic and non-syndromic hereditary aortopathy should include many subspecialties, both to establish the diagnosis, but also to assess the familial risk and to recommend condition-specific medical and surgical management. Last slide. Thank you.
Thank you, Lindsay. What a great presentation. Certainly, there are a few things that make us pause less than pregnancy and connective tissue. I know we've had many discussions of the people that we've held hostage for prolonged periods of time in the hospital, whether it be at Children's Hospital in the delivery ward or if it's in the inpatient side. And certainly they're not happy, we're not happy, nobody's really excited about it. But one of the questions I have for you is, we see a lot of type B aortic dissection, and a lot of us all see this. There is certainly the classic family history of like everyone in the family's had this, or all the other people have had it in the family. There's a long family history. Those are pretty easy, like we should screen for this. But, there's a fair number of people who have spontaneous mutations within each of these categories. And so what would be your takeaway for who you would recommend get screened? They come in, they get through their acute period. Who should we be sending off to, you all? We're lucky here at our institution with you, but certainly who would you recommend kind of get screened that may not have like an extensive family history, but is a high yield for that?
Yeah. So two parts to that. So the first one is it's always best to start with the index case, the person who has disease, especially when you have a family that's undiagnosed. So if we have a patient with an aneurysm or a dissection, that they are already falling in a different category. They're probably more, they have a better yield or a better chance for diagnosis. So I think the index case or the person who presented is always the easiest to start with, as opposed to any of their offspring or either of their parents. The second part to that is, in the absence of really having that ability, I think that, if you have a person who, and between the ages of 50 and 60, I think is a bit of a gray area, but, under the age of 50 for sure, if there is a person that not only has either has a type A dissection or has a type B dissection, with really, a lack of other risk factors, if there's no history of hypertension, high cholesterol, smoking, those kind of things, I think those are the cases that are potentially going to give us the best chance for identification of a gene variant. I think when we have all of those other confounding factors, regardless, I usually say, it's not normal for a 40-year-old to have a dissection, even when they're hypertensive. So there is an abnormality there, but do we know what that is yet? And I don't think we do. I think that in the best case scenario, we're taking the patients and having our best yield for testing when they have little to no other risk factors and when they're the person with disease. So I think, like I said, between 50 and 60 years old, I think our chance for identification decreases a little bit, but under that, that's where we're really getting the kind of 20% of identification rate.
Excellent. This is my shameless plug for your funny looking aorta panel that you all have developed at Children's Hospital. And eventually the FLA panel shall make its way across the country. So.
In fact, we actually call that our surgeon panel because it's our surgeons that send us those patients. So
I mean, there's all of us that look at those and say that just doesn't look right. And so, ultimately, I think you guys all do a great job. But I think that's the most important thing is who do we figure out to make a big impact in their long-term career? And not just for them, but obviously their family as well as, the spontaneous mutations have major impacts on genetic offspring as well.
exactly.
So. Well, thank you very much for your time and what a wonderful presentation and a great overview of who can benefit most. So I'd like to thank everyone and I'd like to invite Victoria, who has now unfortunately suffered with me for the last 3 years as one of our inpatient APPs at the Medical College of Wisconsin. It's only been 3 years, but I'm sure she would argue it seemed like a whole lot more. She specialized in vascular surgery and has here tonight to talk to us a little bit about ongoing management of vascular.
Hi, thank you. Let me just get myself shared here. Oh, I don't need Lindsay's again. Sorry. All right, so again, I'm Victoria Knutson. I'm a nurse practitioner with inpatient vascular surgery at Freighter in the Medical College. And I'm just going to talk about some key points of what not to miss for vascular surgery APPs. I don't have any disclosures to share with you. And I'm just going to go over, review really some vascular disease risk factors that we've really kind of covered already in the previous discussions. But again, management of hypertension, diabetes really makes a difference for our vascular patients. Tobacco use is one of the most modifiable risk factors. And of course, we're always pushing for that. As has been alluded to already, coronary disease usually is a pretty good indication that patients have ongoing vascular disease, kind of tips you off a little bit. And unfortunately, the heart gets all the credit. And, people oftentimes have their coronary disease treated and have underlying, peripheral vascular disease that may be ongoing for quite some time. Renal disease by itself kind of tips us off as well to, damage to some of those smaller vessels. And patients who are on dialysis have progression of their vascular disease at a much faster rate. Family history and traumatic injuries are things that we see as well, but again, not as modifiable. As we've kind of talked about, surveillance and modification of things helps us to treat those patients and prevent progression of their disease faster than if we didn't. Doing our head to toe exam, monitoring the arteries and assessing all of the arteries is key when seeing our patients. Again, as we've talked about, part of the surveillance and preventative measures that we do, assessing, making sure to assess the carotid arteries, arteries of the upper extremities, the abdomen, aorta, and then everything distally as well, the femoral, popliteal, and then distal perfusion in the feet with the DP and PT pulses. As we do our perfusion assessment, it's important to identify whether patients have palpable pulses versus a Doppler signal, assessing again for any bruits that could indicate any stenosis in the carotid arteries, anywhere in the abdominal vasculature, and femoral arteries. Pulsating mass, of course, is a noteworthy finding, generally indicating an aneurysm. Abdomen, femoral, popliteal are common locations for that. Always want to assess the 6 Ps of vascular perfusion: the pain, pallor, paresthesias, pulselessness, paralysis, and poikilothermia, or coolness to palpation. None of our patients seem to have a normal vascular exam even on their best day. So noting a change from their baseline, and whether that's subjective from what the patient is telling you versus objective findings with your serial assessments are really the key factors. It's important also to review your previous imaging, any other interventions, surgical history for these patients. Knowing if we've been surveilling them can kind of give us a little hint if we've had any major changes. Growth in aneurysms, increased stenosis, any new blockages or new occlusions of previously placed stents or bypasses. And knowing their surgical history can really kind of help guide you in the right direction of what you're going to be looking for going forward. Getting into some of the pathology of common findings, we've talked a little bit about carotid artery disease. Again, looking at the history, patients with a history of TIA or stroke or amaurosis, which is, likened to a curtain or darkening coming across the field of vision that's intermittent, are all, predisposing factors that can tip you off to some carotid artery disease. Again, assessing for a bruit, and then a carotid duplex would be your next step in evaluating carotid artery perfusion. Sometimes, especially inpatient, if you have a patient who's had a TIA or a stroke, they've had a CTA, some other imaging of their head and neck for their neurovascular workup, which may lend some information, but again, it's not a vascular go-to. Management is going to involve starting an aspirin and statin if those have not already been implemented previously. Talking a little bit about vascular thoracic outlet. Again, not really a medical emergency, but important to take a history, look at, talking to the patient about what kind of activities provoke the symptoms. Again, the 6 Ps, and then the Adson test, which I will, there's an explanation on the next slide, but the workup can include upper extremity duplex on the affected side, sometimes some CTA imaging, chest or upper extremity to help define vascular disease going on there. So the Adson test is, you have the patient extend their affected arm, abduct it, and externally rotate it while palpating the radial pulse. Then have the patient extend the neck, looking up, and then turning the head toward the affected side, all while monitoring for any diminishment or decrease in that radial pulse that could indicate compression of the flavian artery. To cover a few more upper extremity vascular concerns, we see some vascular access patients at Froedtert and kind of follow along with them. So looking at vascular access, it's important to identify whether a patient has a fistula versus a graft. Little diagram kind of explains simply the difference. Fistula uses native vessel versus a graft, which generally has a synthetic material to build the dialysis access circuit. Important to monitor for or assess for a bruit and a thrill that indicates that you have blood flow through that system. And then, performing a distal neurovascular exam. So make sure that they have a pulse distal to that fistula or graft. Note any, again, the 6 Ps, any paresthesias, numbness, tingling, any changes in that hand. And one of the most important things is when we have these patients, it's important right away, figure out when was their last dialysis, when are they due for their next dialysis, how is their potassium, how are their labs otherwise, and how are you going to dialyze them? Because if you're having a problem with that fistula, that access site, you might have to look at getting them a line, that might be, temporary dialysis line if it's something that needs to be done right away versus, a perm cath if they're going to have, a little bit more extensive work done on their access site. Some of the common dialysis access concerns include bleeding, thrombosis, and infection. Bleeding is pretty self-explanatory. However, you need to differentiate whether it's from the needle access, just from that puncture site, versus if the patient has an ulceration or other wounds, especially on an aneurysmal or scabbed access site. Sometimes holding pressure is obviously your first line of action to mitigate the bleeding. Sometimes placing a figure of 8 stitch is a solution. And given the high volume of these access sites, if there is, in a situation where you have an ulcerated fistula or something that's very aneurysmal, may have to apply tourniquet above that access site so that you can occlude the arterial inflow and prevent patient from bleeding out, which can happen very quickly. Thrombosis of a fistula needs to be resolved and addressed within about 2 days. Generally, that's done with a surgical intervention, surgical thrombectomy, or revision of the fistula. Graft, you have a little bit longer, can be declotted in the interventional radiology. Oftentimes with a fistula thrombosis, patient will require therapeutic heparin, not always necessary with the graft thrombosis. And then an infection, fistula, it's often associated with a thrombosis at that site, can develop an abscess. Again, fistula is native tissue, so can be a little bit more responsive to antibiotic treatment. A graft is more likely to need surgical intervention and may even need an explant given the fact that it's synthetic tissue, not going to respond as well to antibiotic treatment. Moving on to the abdomen and looking at some of the basics of aortic diseases, the dissections and aneurysms, covered that pretty well already. And again, reviewing the patient history, hypertension, substance abuse, if they're having any pain, what's the nature of the pain, if they can describe it, when was the onset. And then as far as the exam, palpating the abdomen for a pulsating mass. If you have a patient that you're concerned for an impending rupture, of course, you don't want to go palpating that abdomen. But assessing the distal perfusion, down the legs, femoral, popliteal, and distal arteries. And again, assessing your perfusion based on your 6 Ps. If you have a dissection that is occluding some of those distal arteries, dissecting down, you may have impaired blood flow down to the legs. Working up, obviously, we do a CTA of the chest, abdomen, and pelvis. And then we're also going to watch labs and things too if we feel that there's in a case of a dissection, involvement of the renal arteries that we need to be monitoring for kidney function as well. Management in the immediate setting is blood pressure and heart rate control with that impulse control again. Really aggressive generally with a systolic less than 120 and a heart rate less than 80. That's kind of guided by patients' experience of symptoms as well. Sometimes patients notice a lot of that pain and some of their symptoms improving once we get better blood pressure control. Another abdominal topic is mesenteric ischemia. There's the acute versus chronic. And again, this has kind of been covered already. But looking at the patient history again, assessing for postprandial symptoms. And I think that we talked a little bit about food diary and, looking for that. Some of the other things is the food fear, weight loss over the course of, the preceding months. Again, if you're following in an outpatient setting. What we're more concerned about on the inpatient side is an acute on chronic event. So again, all of this history can kind of tip us off to let us know if, that history supports a possibility of having, an acute occlusion of mesenteric vasculature. Again, the pain out of proportion to exam, this is ischemic pain. So it's not necessarily like the peritonitic pain. It's very different, very intense. And again, the exam showing signs of malnutrition can kind of point you in that direction and support your suspicion of an acute event, especially if they have previous imaging and previous monitoring and surveillance for a known chronic event. I think we talked about duplex ultrasound of the mesenteric vasculature, and that's more of a screening. If you have a patient who's experiencing an acute event, you're not going to be able to put an ultrasound probe on them to do an exam. CTA of the abdomen and pelvis will give us a little bit more information, kind of guide things. A lactic acid that's elevated, increased white blood cell count are late signs of ischemic tissue. And if you think about you have an ischemic area, you're not getting any blood flow, even if there is lactic acid being produced in that ischemic tissue. It's kind of locked up in that area. It's not moving out into systemic circulation where you're going to be able to capture that. So it's not something that you would use to necessarily guide your treatment. Again, that would be something that would be more of a late sign, but they already have some damage to their intestinal mucosa. Talk a little bit about lower extremity disease, claudication, which is the leg pain that gets worse with ambulation and, the demand, kind of a demand ischemia really of the legs. Looking for rest pain, and that is, most often characterized by patients. We see it in the hospital and they'll report at home as well that they're hanging their bed or their leg over the side of the bed while they're sleeping at night. And that's just having that extremity dependent, uses gravity to kind of help that blood flow, make it a little bit more distal. And again, this is something where our patients don't ever have a normal vascular exam, but people that will, be brought into the hospital with this increasing rest pain, that has gotten worse in the last couple of days, that's an important part that you have to capture and can really kind of tip you off that there's something more going on in the setting of a chronic vascular disease. So again, pulse exam, assessing for any wounds. One of the key points that you have to watch for is, especially in interdigital in between the toes, you can have a little bit of skin breakdown, and it's really easy to miss that, I think. But that's a really good sign that patients have some ischemic tissue and things are, not looking so good for them. Assessing for a pulsating mass, especially popliteal, we talked about already, to possibility of thrombosis from those popliteal aneurysms. And again, looking at those 6 Ps, change from the baseline is, one of the key points as well. Looking at your workup, you're going to get ABIs, chronically to follow these patients. And that's something you'll want to look at, previous ABIs and kind of where was this patient heading with their vascular disease, if they've been following in clinic. And then CTA of the pelvis with runoff will give us a little bit more definitive answer about their perfusion. Angiography with intervention, of course, if we have an acute limb, we can, place stents, we can do angioplasty. Sometimes patient can require like thrombolysis, and that can be ongoing for a couple of days if necessary. So moving on to a little more systemic, looking at a thromboembolic workup. So anytime that we have this chronic disease, we have stenosis somewhere, and we have this acute onset of, ischemic pain, ischemic symptoms someplace, we need to sometimes look at where, was this a thromboembolic event? Was this a narrowing in an artery someplace? And there was a little clot thrown or something happened that, occluded that last little trickle of blood flow that they kind of had that they were working with. And in doing this, it's important, again, history, talk to the patient, assess their compliance with their antiplatelet or anticoagulation medication regimen. Some of the DOACs are very expensive. Patients have insurance changes. Sometimes they go off of their DOAC and really run into problems. And sometimes it's really no fault of their own. So one of the other considerations that, you have to kind of keep in mind. Then considering cardiac monitoring, a Holter monitor if, patient is discharging and you haven't been able to capture anything. Always a bubble study with an echocardiogram to look for any kind of shunting or septal defect that could indicate that there is, clot that could be passing through. And then CTA of the chest to look for any other microembolic events, and a hematology workup as well if you can't find any other good explanation, just to see if they have any propensity for any hypercoagulable states. So in summary, most of these chronic diseases involve some degree of arterial stenosis, and that really is kind of what vascular disease is. And all of the acute things that we're looking for really is just an acute worsening of that stenosis that really ends up being a complete occlusion and leading to the ischemic tissue. Assessing for aneurysms, there are assessing for bruits that can tip us off to aneurysms. If they're occurring in one area of the body, it's very likely that they're also someplace else. So doing a thorough assessment, not only of the abdomen, and carotids, but also, assessing popliteal and femoral as well. And again, talked a lot about the acute and chronic disease. And then therapeutic heparin is really kind of first line management for a lot of our patients. If you have this acute thrombosis, acute embolic event, treating them with heparin to try and improve that blood flow is always going to be our first line of treatment. And then modifying risk factors. It's, old news to tell people that they need to quit smoking and manage their blood pressure, but some people maybe haven't heard it enough, and that's why they're coming to us. And if we aren't telling them to quit smoking and manage their blood pressure, what other things are we not telling them? So just being comprehensive and making sure that we cover everything, and touching on all of the things to really empower patients to take care of themselves can be an important factor in helping them to maintain their vascular health.
Excellent. Thank you so much. What a nice summary of everything presented there. I think probably the one shameless plug I'll always put in there is that, it's never really hurt anybody doing that thromboembolic workup. And certainly lives, limbs, strokes have all been saved by finding that AFib in the person that's randomly presenting with other things. So kind of my shameless plug for a thromboembolic workup and a Holter monitor. So thank you to all of our presenters who took the time, as well as all of those that attended this evening and the questions and comments presented. I hope that everyone can attend the APP section portion of the MVSS meeting this upcoming September. I believe it's held Friday from 8 to 12 is the APP section, with a focus on aortic as well as aneurysmal disease, and then followed by a small meet and greet. So thank you to everybody tonight, and hope everybody has a wonderful evening.